Recording in progress.
A very warm welcome, everyone. Good morning to those on this side of the globe, and to Dr. Yuli and all our colleagues joining us from around the world. Good afternoon, good evening. It is my absolute pleasure to welcome you all to this special event held in conjunction with Global Dental and Oral Trauma Day, which is today, the 21st of September, a day dedicated to raising awareness, sharing knowledge, and advocating for the prevention and improved management of dental and oral injuries worldwide. On behalf of the Malaysian Association of Paediatric Dentistry, it is our great honor to begin today's program by sharing a recorded message from the President of the International Association of Dental Traumatology, Dr. Liren Levin. Let us now take a moment to hear from him.
Hello, my dear friends in Malaysia. It's a great pleasure on behalf of the IADT to welcome you to this event. It's a great way to celebrate the Global Dental and Oral Trauma Day that was inaugurated last year by the IADT. This day is a magnificent way to enhance and promote knowledge around dental trauma, prevention, treatment, and education. And I think we all need to do that not only amongst ourselves like you're doing today, but also to our communities, to parents, to coaches, to people that are dealing with kids and adults and might suffer from dental trauma. So thank you very much for organizing this day. I'm very sorry that I couldn't attend this time, maybe next year, maybe in person. And I hope that you will enjoy. I know that you're in for a treat with your speaker today. She is a great speaker, so you will enjoy that. And I would like also to provide a little surprise or a present from the IADT. For those of you who are not members of the IADT yet, this is a great organization with people like you that are interested in dental trauma and that really care about our patients and want to promote this issue and provide the patients the proper education, the proper measures for prevention, but also the proper treatment when they get dental trauma. So I encourage you to join us and to enjoy the many benefits that this association can offer you. And just for this day, if you're a new member and you've never been a member of the IADT and you will register today, you'll sign up today or tomorrow, I'll extend it in one day, you will become a new member of the IADT. You will get the next year membership for free. So if you will sign up today for membership in 2025, you will get 2026 for free. So I will ask the organizers to send us a list of people that are interested and participated in your event today. And if you want to become members, you're more than welcome. We'll be happy to welcome you to our great association. You'll meet awesome people from all around the world. And I'm looking forward to seeing you also next year in our World Congress in Dental Traumatology that will be held in Warsaw in Poland. So thank you very much for organizing this today. Thank you for inviting me to give these greetings. I'm sure that you're going to have a great time and an awesome lecture, and I hope to see you as IADT members.
Thank you, Dr. Levin, for those inspiring words. To everyone participating today, don't miss this opportunity to register as an IADT member and enjoy free membership for the year 2026. We now move on to our main session for today. We are truly delighted to welcome our distinguished speaker for today, Dr. Yuli Berlin-Broner. Dr. Yuli is an associate professor and former acting head of the Division of Endodontics at the University of Alberta, Faculty of Medicine and Dentistry, MAPD School of Dentistry, where she coordinates pre-doctoral education in endodontics. Her academic journey is both impressive and international. She earned her Doctor of Dental Medicine, completed her postgraduate endodontics specialty certificate, and then furthered her specialization in the endodontics specialty program at the University of British Columbia. She also holds a Master of Science in Oral Biology from the University of Alberta. Dr. Yuli is a Fellow of the Royal College of Dentists of Canada and the International Association of Dental Traumatology, where she serves as an elected board of director. She has published widely, presented at numerous national and international conferences, serves as a peer reviewer for several scientific journals, and is an editorial board member of the Dental Traumatology Journal. Her research interests include endodontic systemic relationships, educational methodologies, and dental traumatology. Alongside her academic role, she also maintains a private practice in Edmonton, Alberta. Please join me in giving a warm welcome to Dr. Yuli. Dr. Yuli, the virtual floor is now yours.
Thank you, Loshini, for the introduction. And thank you to President Dr. Liran Levin for his message. And I welcome you all, my friends in Malaysia, from Canada, Edmonton. And today we are going to celebrate together the Dental Trauma Day. So actually here in Canada, Edmonton, we are 14 hours behind you. So we are still on September 20th. So I'm going to celebrate it 2 days, today and tomorrow. Today with you and tomorrow here in Canada. I thank the Malaysian Association of Paediatric Dentistry for the collaboration and for the invitation. And I'm excited and thrilled to be talking to you today about a topic that is very close to my heart, dental traumatology. And specifically, we are going to spend the next 45 minutes and then probably the rest of the time for questions. We're going to be talking specifically about the long-term implications and considerations in treatment of traumatized immature maxillary incisors. So that's the nice poster for today's webinar. And just to say that I have no conflicts of interest to declare today. And those are some pictures from Edmonton and the University of Alberta. Now we are in the fall season, so it mostly looks like in the picture in the left middle side. But soon, around November, it is going to be snowing a lot with temperature that can drop to minus 30 and even feel like minus 40 Celsius. but the city is pretty adapted for this cold. So inside we can dress up comfortably and dress up very warm or be in the car outside, and then everything works well. So I invite you to visit Canada and visit Edmonton and the University of Alberta. Actually, next year, the Canadian Association of Endodontics will be taking place in Vancouver, which is, yeah, a city worth visiting. So, as Dr. Levine mentioned, and this is a picture of all of us, the board of directors of the International Association of Dental Traumatology. This picture was taken in Japan in the conference last year in 2024 in July. And this is when the Dental and Oral Trauma Day was launched. And now we celebrated to increase awareness and talk to our patients, talk to faculties and students about dental trauma. Diving into today's topic, I'll start with this picture that shows the mixed dentition stage around the age of 6, 7, where we have primary dentition and permanent dentition starts erupting. And ideally, in the ideal world, we would like to see a nice transition to harmonic dentition in an adult age. However, not always this happens, and dental trauma can occur in between, resulting in pictures like that. For example, on the left, 20-year-old student, she was student at that time. And then on the right, we have a very young adult. She was 9 in this picture. And dental trauma can unfortunately disturb the harmonic dentition and the transition to permanent dentition. Dental trauma is pretty common in the world, and it involves, out of the 8 billion people in the world, it involves about 1 billion. And which is 12% of the world population. And it is mainly common in the school children age, involving as much as 1/4 of the school-aged children. Because dental trauma is so common and has so significant impacts, there is a lot of attention given to that topic in the literature. For example, in this last collaboration between the different organizations, the Sports Dentistry Organization and the International Association of Dental Traumatology, guidelines were published for prevention of dental injuries. Probably it will take some time to see the impact if those guidelines can reduce dental trauma, but dental trauma will keep occurring. So let's look together at the characteristics of the group that has the most common dental injuries. So as we said, those are school-age children, mostly between the age 8 to 12. The tooth that involved the most are the maxillary incisors. Males predominate, females as twice higher. And what is special to that group is that we're talking about immature dentition. So on the picture on the right, where we see a radiograph, we can see the upper right maxillary incisor with an immature root. As you can see here, the crown to root ratio is not preferable. So the root is short and it is almost the length of the crown. We can also see that the apex is immature, the apex is open, the walls are very skinny. So the tooth is not only difficult to be treated with the tooth is not only difficult to be treated, but also it is risky for the tooth to stay like that because the periostatus is not preferable and there is a high risk for fractures such as cervical fractures in the root. This age of kids, the 8 to 12, as we said, is characterized by the developing of permanent dentition. And also, this is the stage of orofacial growth. So the teeth are growing, the maxilla is growing, the mandible is growing, and there are constant changes between the arches. In this age of children, the 8 to 12, or the teenagers, there are specific characteristics. So it is known that this group has high aesthetic demands. Well, in any age there might be high aesthetic demands, but especially in this group where they're developing their social connections in school, they really care about their aesthetics and their looks. At the same time, we have very limited restorative solutions because we cannot offer those patients treatment modalities like implants or bridges or anything that will intervene with the growing and the changes, the skeletal changes. In this age, which is the growing period, there is also rapid turnover. So diseases develop very fast on the one hand. On the other hand, there is also positive reaction for treatment, positive response faster than in adults. And as I said before, we talk about immature teeth with the difficulties. Now, compliance can be a challenge because the kids, they do not come to the dentist by themselves. They're dependent on their parents. So compliance can be an issue because parents can be busy. They cannot bring the child to get care in time. Sometimes there are different statuses between the parents if the family is united or not united, different conflicts. And so compliance can be a problem. And of course, there is a high risk of reoccurrence because if dental trauma happened once, to the child, there is a high risk that it will happen again, as it depends on the habits and the environment and the temperament of the child and the bite relations between the arches. For example, we know that class 2 dentition has a high risk because when there is class 2, the interrelation between the maxillary teeth and mandibular teeth is such that in case of dental trauma, the lower arch does not protect the upper arch and there might be fractures of the central incisors. So one evening in November, just before Halloween in Canada, this young boy, Will, went out for a ride on his scooter. He fell on the ground and unfortunately his maxillary incisor was avulsed. Will was stressed. He didn't know what to do. It was dark. He called his mom. Mom came to the scene. They went home. They didn't think about looking for the tooth. And at that time, Will was 13 years old. Now we will get back to the story of Will as we go. But this is to show a panoramic radiograph showing the missing central incisor in a 13-year-old boy. 1 week later, Will came to the dental office. He was referred to see a periodontist and to assess the situation. And as I showed before, the central incisor is missing, and we see the clinical photo here below, where we see the missing tooth and the fractured teeth adjacent to it. The situation can result, like in Will's case, tooth loss, tooth fracture, change of color, pain, stress, uncertainty, multiple visits that are hard to visit, and other things that we spoke about. So, and it's like throwing a dice kind of with dental trauma, because there is a lot of uncertainty and a lot depends on the type of trauma and the treatment that is applied. And we know it was described by Andreasen, who is the father of dental trauma, that there might be as much as 96 different variations of dental trauma combined, like luxation with crown fracture, root fracture, and so on. In 2023, we published a paper in the International Dental Journal talking about improving the well-being of the patient as a broader perspective in dentistry. Because of those many aspects that are involved in dental treatment and in dental trauma, we suggested, and we were not the first ones, but what was innovative in the paper is that we suggested a summary how to look at the patient's well-being and improve it by considering everything together, which is the dental health or oral health, mental health, general health, stress level, and social health that are interchanged. Now, this picture was taken in the grassy lakes in Alberta, which have this nice green color. And I noticed later that in the picture, there is this effect of the light kind of coming out of the water with the lens. And this wasn't to bring the next paper forward to you, which the lecture is moving around that one. So today I want to enlighten you about the implications of post-traumatic treatment of immature maxillary incisors. And you are welcome to download that paper and have access to that. It was published in the International Dental Journal, and what it talks about, it emphasizes the importance of the treatment focusing not only on the acute phase of the dental trauma, but considering the long-term implications of the treatment. And it suggests a roadmap, a summary here of all the implications to consider when treating dental trauma. And today, briefly, we will dive into those categories and talk about the important ones as much as possible in the given hour together. So fractures, cracks, they found or different fractures. The fractures are being categorized and recategorized with different classifications. But fractures, they can start from craze lines, which are limited to the enamel. They can progress to cracks, which involve dentin, and then cracks can be deeper and extend all the way through the root from side to side, and then it will be called split tooth. We will not go into all the categories, but that picture shows a case of a 34-year-old female with history of dental trauma, and we see those crack lines, fracture lines in her crowns of the central maxillary incisors. Now, after taking 3D scan, CBCT, radiolucent periradicular lesions were noticed. So we see a small periapical lesion on the left incisor and the lateral lesion on the right incisor. We can also see with what happens many times after dental trauma that the teeth have some significant degree of calcification or obliteration. So tooth number 11 was treated with a conventional root canal treatment, and you can see the nice lateral canal sealer puff here, which explains the lateral lesion, which is always nice to see because a differential diagnosis for a lateral lesion can be a root fracture. So when we see such a nice sealer puff, it kind of reassures us that yes, there was a lateral canal. There was a difficulty, there would be a difficulty to locate the canal in the left upper maxillary incisor. And taken together with the fact that it has a crack in the crown, I took the decision not to treat the tooth orthogradly, not to weaken the crown and extend the crack, but to do apical surgery on that tooth. So that's, for example, a consideration. So as opposed of going conventionally with a primary root canal and then secondary apical surgery, here was the decision to do the apical surgery. That's an important paper that is beyond the scope of today's lecture. It doesn't have to do with dental trauma, but I thought to just to mention it to you here, the Iowa Staging Index, that was published in the Journal of Endodontics in 2018, and it is cited many times. And what they found, they looked at lower molars, and they looked at outcomes of teeth that had cracks. So lower molars that had cracks. And upon follow-up, they noticed that there were three main factors determining the prognosis of those teeth. So number one, the pocket depth. Number two, if the distal marginal ridge had a crack. And number three, the periapical diagnosis. So the worst success was when there was a pocket of 5 millimeter or more. And this was the strongest factor, dropping the success rate of those cases to 41%. However, if there was no pocket and it was the distal marginal ridge involved with the crack, that was the best prognosis of 93%. So this case I treated in 2012 as an example for vertical root fracture, kind of dropping the ball here ahead of time. But I saw that patient when she was 18 years old, and it was an old attempt for revascularization, and there was MTA here in the pulp chamber or in the root canal space. The tooth was also discolored, so in this case, a retreatment was performed. The tooth was obturated with an MTA plug. There is also fiber post that was used to restore the tooth. There are different options to restore. Composite can be placed, fiber post can be placed, gutta perca can be placed all the way to the cervical area. There are different literature reports out there. Some find an advantage to use fiber post to strengthen the root, to reduce fracture, but others don't find differences. So there is still no answer what would be the best method. And those teeth are weak. 10 years down the line, 2022, I received an email saying that the patient was seen for a follow-up and the vertical root fracture was found. So I was very upset when I read that. But when I continued reading the email, it said the patient mentioned that she was very grateful that she could use the tooth for 10 years and now she can have an implant. So why am I showing you this case? I'm showing you this case because looking at the image on the left, we may think, oh, maybe it's better to extract the tooth tooth number, the upper right maxillary incisor, and just place an implant. However, the young age of the patient, who was 18 or 17, that time did not allow placing an implant, and it could result in bone loss at that stage. So then patient had 10 years to use that tooth. I wish patient, depends also on compliance, the best would be to discover the vertical root fracture as soon as possible before there is more bone loss. Crown fractures. In this case, the patient came with the fragments of the crown in their hand, and they were placed back by the dentist. There was a lot of dilemma. So this was done as a first aid. And then the patient was referred to me as an endodontist. There is a lot of dilemma if to enter to those teeth. Are they vital? Are they not vital? But upon follow-ups, there was no response to EPT, and the patient was symptomatic for percussion. The decision was made to enter into the teeth and start a root canal treatment, and the pulp was necrotic indeed. So we have a follow-up of a year. The teeth were stable and asymptomatic in the mouth. This case is to show that on the one hand, we want to allow teeth to mature. On the other hand, we want to prevent infection and prevent bone loss. In this case, the teeth were full length apices. The walls were still not very thick. So allowing maturation would allow thickness of the walls, but then if the patient is lost on follow-ups, then there might be infection developing. So we want to diagnose the pulp necrosis on time and to treat in time. So overall, for fractures, things we have to have in mind is sometimes, I will start from the end, sometimes we want to consider regenerative treatment to elongate and increase the thickness of the dentinal walls, but we need to be very picky with those cases. For example, when the roots are long already and the walls are thin, I wouldn't choose the regenerative treatment because it is less predictive in the literature. I would choose something definitive as a root canal treatment. However, when the root is very short and crown to root ratio is not preferable, like in the first case I showed you, I may consider regenerative treatment, but knowing that it's very not predictable in the outcome, like in the case that I showed you that failed and ended up with a conventional root canal treatment at the end. Have in mind the different restorative options for the cervical area, such as fiber post or composite, and I suggest to stay on top of the literature in that direction if something new comes up. And yeah, there is a tendency to avoid long-term calcium hydroxide intracanal medication because there is evidence that it weakens the root and causes more fractures, like more cervical root fractures. So instead of long-term calcium hydroxide intracanal medication for apexification, I would probably choose in those immature cases to use immediate apexification with bioceramic materials such as MTA or other bioceramic materials like biodentin or others. So going forward with the enlightening, the dental trauma can impair the growth and development of the jaws. It can result in a missing tooth, malocclusion, ankylosis, replacement resorption. And this is a case of a young patient at the age of 9 when they had the trauma. And there was a long time before getting to treatment. So they came in this condition where we can see that the upper right lateral incisor is missing, at least in this picture. There are fractures of the anterior incisors, malocclusion, sinus tract near the upper left lateral incisor. So that's a small meme because this is how we learn nowadays. And to give a small break, what happens in mature teeth when they undergo intrusion? So we know that the worst trauma outcome would be when we have a mature tooth with a closed apex that has undergone intrusion. So here it says, develop teeth after intrusion injuries. I guess I will die. So yeah, probably they will die. And this is what happened in this case. In this case, the teeth were immature when it happened. So some of them, I will speak about each one separately. So the anterior teeth, they were mature. So the apex was pretty close. They undergone necrosis. They were treated with root canals. And then the upper right maxillary incisor actually disappeared in the gums, but it was there. It is deeply intruded. And what you can see here on the X-ray is that there are changes in the root surface. We have replacement resorption happening in the cervical area, and we have invasive cervical resorption happening in the crown area. So the patient had preparation with orthodontic treatment to fix the malocclusion, had some root canal treatments done, and then the question was what to do with the lateral incisor that is so much intruded and it is so deeply under occlusion. So the options that exist are extraction, and option number 2, which was chosen in this case, it was decoronation. So decoronation is a treatment modality in which the crown portion is removed and then the root portion of the tooth stays and buried under the gums. And here, if we look through the procedure, we can see the tip of the incisal edge of the tooth sticking through the gums. It was exposed with full thickness envelope flap, a very small flap extending from the canine to the central incisor just to expose the crown. And then high-speed burr was used to cut the crown away, and the canal was exposed. If we follow the protocol by Malgram, bleeding is induced in the canal, and then the gums are covered above the root. What this allows, so this is immediately, this X-ray was taken immediately after the procedure, and it shows the buried root under the gums. And then on 1-year follow-up, you can see how nicely we have bone above coronal to the root fragment without loss of the height of the bone. So in other words, we have preservation of the ridge thanks to the piece of the root that stayed inside of the bone. Because if the root is extracted, we know that there might be some massive resorption. And clinically, we can see here on the top the pictures prior to the procedure and then 1-year follow-up. The patient was given a removable device to to leave the gap for a future implant and also as an aesthetic solution. I know it's not ideal and it depends on the compliance of the patient. What we see here on 1 year follow-up is that, yes, there is some bone loss in the horizontal aspect in the buccal, and that always happens, but we have the height of the crest preserved and more bone for future implant. Moving ahead to our patient Will from before, who lost his tooth and a panoramic was taken. The options that exist here in the age of 13, well, ideally, we would like the tooth to be preserved, and immediate reimplantation would be the most beneficial. But in this case, the tooth was lost. So when he came a week after, the options are limited. So something I want you to have in mind is the option of autotransplantation. And this case was published in the in the Dental Traumatology Journal, showing that there is a possibility of extracting a premolar and implanting it in the area of the anterior tooth. Depends on the stage of the maturity of the root, if root canal is needed or not. In this case, we tried to avoid the root canal, but then we have the inflammatory root resorption, which was pretty severe. So we controlled it with calcium hydroxide medication, intracanal medication, and then conventional root canal. And upon follow-up, we had eventually 7 years follow-up. We can see that the PDL is continuous and the resorption is not progressing and the teeth are stable. So it a lot depends on case selection in those cases. This just shows some pictures from the procedure that was done by Dr. Liran Levin. He did the surgical procedure. I did the root canals. So Dr. Levin prepared the site for the auto-transplanted tooth. And then the premolar was implanted there, stabilized with the splint. So yeah, maybe it doesn't look aesthetic in the beginning, but the truth was that the patient was just happy to have a tooth in there and not to have a gap. And then with the help of prosthodontist Dr. Torrealba, who did the restorative solution, composite restorations were done, and then the teeth were moved orthodontically. And the patient grew. So he was just a little bit higher than me, taller than me, and he grew much taller. Now he is probably 20, in his 20s. The tooth is still in his mouth and he is grateful to have it, right? So always think about what are the other solutions. What would be if he would lose his tooth at the age of 13 and have nothing there, or something removable and a lot of bone loss for a future implant. In his case, by the way, the extraction of the premolars was needed for orthodontic reasons. So the treatment plan was done together with multiple consultations, multidisciplinary, with a periodontist, endodontist, orthodontist, and prosthodontist. So things to have in mind in the growing organism of as in children is that we want to avoid extractions as much as possible to allow the harmonic growth, and of course replantation of the avulsed tooth as soon as possible. If not possible immediately, then to use a storage medium. Probably the most feasible would be milk because it's the most available around. Or even the patient can keep the tooth in their own saliva under the cheek until the tooth can be replanted. Consider autotransplantation, like was showed in this case. Consider decoronation in case of a significant intro or even infraocclusion, like in the case I showed you earlier. And sometimes we need to use removable partial denture until the completion of the growth. Orthodontists should be involved, I believe, in the treatment planning because it can have an impact on the selection of treatment we choose eventually. Next on our list would be crown discoloration, just very briefly. So teeth may have different discolorations such as gray, pink, yellow, caused by different conditions, right? So for example, in the picture above, there is gray discoloration that was caused by MTA that was placed close to the cervical area of the tooth. Now there are newer bioceramic materials that cause less staining, fortunately. There might be pink discoloration, like in this orthodontic patient, which may be a result of some resorption that develops in the tooth. Or it may be transient, like I will show you in my last case soon. Or there might be yellow discoloration as a result of pulp canal obliteration. So if the tooth doesn't become necrotic after trauma, most likely there will be some yellowish discoloration as a result of obliteration. So in this case, gray discoloration, as I said, due to MTA staining, and then there was an internal bleaching performed and the tooth became lighter. Teaching at the university, I get questions from students, and that's to share this canine. So what do you think may be causing the discoloration? So if we look carefully on this picture, and this is something I wanted to share with you just to have in mind. If we pay attention, the gutta perca is extending all the way to the coronal area. So of course, if we have obturation material in the crown, it will cause discoloration. So ideally, where we want to finish the root canal treatment is below the CJ. So if the bone level is somewhere here, when I will use the color. If the bone level is somewhere here in the tooth, so I would finish the root canal somewhere here below the bone, because anything above here will eventually cause discoloration of the tooth, and it is preventable. Just want to get rid of the drawings. There we go. So sometimes when we look to distance, this picture was taken in Tokyo at the dental traumatology meeting 2024. I was standing here in the fog looking into the distance and looking at this endless field of little trees. And if we look carefully, we may see the details. So it was an amazing field of those little trees which were perfectly symmetrical. So for me as an endodontist working under the microscope, it is something very nice to see. And showing you this because I want to draw your attention to an entity that we all should have in mind after traumatic injuries. So this paper was recently published, a collection of cases by Dr. Tsukibushi. He has a very large collection of cases with long-term follow-ups, and I heard that he's coming to your area sometime in the very near future. So this is very exciting. Really recommending to listen to him in person or read his papers. So in this publication, we worked on focused on transient apical breakdown, or TAB, incidence, pathogenesis, and healing. So the TAB was already reported by Andreasen in 1986. Dr. Andreasen reported that approximately 4% of all the luxated injuries showed this transient apical breakdown. What Dr. Tsukibushi added, he added more cases, and we were interested to look at the cases that show transient apical breakdown and to see what are the characteristics of those cases. And this is a picture with myself, Dr. Levin, Dr. Tsukibushi on the right from Japan, and what the transient apical breakdown phenomena is about. A theoretical mechanism is explained behind it. So it happens in mild injuries such as subluxation or small extrusion or sometimes small luxation injuries. On the top, you can see CBCT slices of a central incisor, and on the lower bar, there is a diagram or illustration that shows the suggested mechanism of what is happening there. So in mild trauma, we have some degree of trauma in the periapical area. So you see here a thickened PDL space in picture A. And this thickened PDL space, there is some hemorrhage happening there and some inflammation. So you can see here later, there is some small radiolucency developing in the apex in picture B. So there is some inflammation, but because the trauma was mild and there is no infection yet, the tooth is able, there is a process undergoing there of the inflammation. And as a side effect of inflammation, there is some degree of root resorption. So if you look at picture C, we see resorption of the root. And the resorption of the root results in a thicker apex or bigger apical foramina. So if in the beginning in picture A we had a closed apex, now after the changes in the apical area, the apical foramina is bigger. This allows a more effective vascularization getting into the root, and this allows healing of the inflammatory process and obliteration of the canal. So you can see here upon follow-up on D, the canal becomes narrower, the walls become thicker, and we have obliteration. So from the collection of cases from Dr. Tikibushi's clinic, we see, I just show here an example of an incisor, upper right maxillary incisor with a mild trauma. We see in picture A that the tooth is extruded, and then picture D, the tooth changes in color after 3 weeks. There is a pink discoloration that is appearing, and there was no rush to start a root canal treatment. So that's exactly what the paper is talking about. We don't want to rush in those mild injuries to do a root canal treatment. Even if there is no response to cold, no response to EPT, we wait and see. And in this case, eventually the pink discoloration disappeared. And there is some yellow discoloration appearing in that tooth we see in picture R. So that tooth was followed up for 10 years, and we see, significant pulp canal obliteration in S. So wait and not necessarily start a root canal treatment. So this was to show that some phenomena may be transient. I'm not going to talk about resorptions because it's beyond the scope of this lecture, but just listing them here. It mentioned invasive cervical resorption, internal resorption, inflammatory resorption, transient apical breakdown that you are familiar with. I'm also not going to be talking about infections that are beyond the scope of this lecture. If you are interested to read about resorption, I do recommend those papers, part 1 and part 2, tooth resorption in the Dental Traumatology Journal, or the root resorption that was published in the Colleagues of Excellence just last April by the American Association of Endodontics, spring 2025. So to sum up, what I want you to take out from this lecture is that when we treat young adults, we choose treatment modalities, we want to have in mind that, of course, we need to take them out of pain. We want to clear infection, and we want to prevent infection, first of all, pain and infection. And we want to address the social aspect of the patient. And everything is related to the social aspect. The aesthetics, pain, and infection. And overall, we want to extend the time of the tooth in the oral cavity in order to allow bone preservation and normal development of the jaw bones. Orthodontic considerations should be taken as well into account. You're welcome to visit, the International Association of Dental Trauma website, where you can access the guidelines for dental traumatology, the latest guidelines from 2020 for free. And you can also find the dental trauma guide and as a tool, very useful tool to use about treatment decisions. I would also mention the Tooth SOS mobile app that is free for download, and the interface can be used and recommended to patients to use, like what to do if this or that happens. There are nice pictures and nice summaries. So you are welcome to download this app. And in the memory of Jannes Andreasen, the father of dental traumatology, I had the privilege to meet him in 2017 in San Diego, and here I'm standing next to him, and that was the first and last time I saw him, but he had a significant contribution to the world of dental traumatology, and we try to continue his legacy by celebrating this day of dental traumatology. This picture is of the Three Sisters, famous three mountains in Alberta. There's a lot of art around those Three Sisters. And yeah, this season is coming soon. So the ski season is starting as well soon. And the three sisters lead us to the last three points that I want you to take from today's lecture. So treatment of immature maxillary incisor goals should be teeth retention, number one. Number two, alveolar bone preservation. Number three, patient's well-being. I would like to thank you for listening and for celebrating the Dental Trauma Day from all around the world. And we are a team. We are a team together, the different specialties, periodontics, endodontics, pediatric dentist, general dentist. We should work as a team to make our patients' lives better. Thank you. And before I address the questions, I also want to extend the invitation to the next Congress of Dental Traumatology that will be happening in Poland, Warsaw, in September 3rd to 5th in 2026. Thank you. Now, I see a few.
Thank you, Dr. Yuli, for the insightful presentation. We now open the floor for Q&A session. So I will read out the questions that are posted. So we have one question from YouTube. If a tooth is ankylosed, does that mean that the pulp is necrotic, or is it only a periodontal injury?
Yeah, so that's a great question. So ankylosis, I will just define it first. Ankylosis is a condition when we have direct contact between the tooth surface and the bone surface with no PDL in between, without periodontal ligament in between. Ankylosis can be immediate by trauma, when the PDL is smashed and the cells are killed and there is direct contact. And ankylosis can also be as a result of a process of remodeling of the bone, where we have replacement resorption, when the tooth itself is replaced by the bone. So ankylosis is a condition, to answer the question, is a condition in the related to the periodontium, and it is not related to the vitality of the tooth. In other words, the tooth can continue being vital. For example, if it was an immature tooth with intrusion, the tooth can continue being vital. However, there might be some areas of ankylosis in the periodontium around the tooth. Another area where ankylosis can happen is sometimes in invasive cervical resorption, when the tissue is replaced, when the tooth tissue is replaced by bone. That's another area of ankylosis. Yeah, so they are not related.
Okay. Next question. Good morning, doctor. Thank you for your enlightening lecture. May I know how long would you wait and see for TAB?
Yeah, so that's a great question. How long we wait and see for transient apical breakdown? So in Dr. Tsukibushi's cases, he showed that even after 12 months, sometimes the I shouldn't say vitality, I would say sensibility came back. So he had a few cases that no response to cold, no response to EPT, and then follow up. And then suddenly after a year, the tooth did not respond to cold, but EPT came back to respond. Cold may be challenging because there might be obliteration or narrowing of the canal space and thicker dentin, less pulp tissue. So cold is less responsive, but EPT returned responding. So yeah, he showed cases even up to a year. So I would say, as a rule of thumb, if there was a mild trauma, you want to follow up and wait. So if there are no symptoms, no percussion sensitivity, no palpation sensitivity, there is no increase in the size of the lesion, and the tooth is not turning dark gray progressively, I would wait longer before starting a root canal treatment. Yeah, I would wait for more signs and symptoms before starting a root canal treatment. Yeah.
Okay. Next question. If the tooth is already obliterated, what is the next step?
Yeah, so if the tooth is obliterated after dental trauma, we know that actually there were studies that were done about that. I think it's Holcomb, for example, one of them. They showed that if we take all the obliterated teeth after dental trauma, there is a low percentage of them that develops a periapical lesion. So it was reported between 8 to 16% that develop periapical lesion. So most of them, they won't develop periapical lesion. Actually, obliteration, it's a sign that the tooth is vital because it continued creating the dentin. So if there is no pathology, if there are no symptoms, no percussion, palpation, sinus tract swelling, if there is no periapical lesion, that tooth does not require any treatment. The obliteration can be left alone and let be.
So we just monitor the tooth.
Yeah.
Okay. Next question. What do you do with ankylosis of anterior tooth? Decoronation, perhaps?
Yeah, so the question, I'll just repeat the question. What do you do with ankylosis of an anterior tooth? So I will divide my answer for kids in growth period and adults. So first I will talk about adults. So if an adult has an ankylosis, the question was about ankylosis, right? Or
yes,
infillocclusion?
ankylosis.
Yeah, okay. If an adult has ankylosis, let's say the adult had an avulsion and then the tooth was replanted right away, and let's say on follow-ups, the tooth develops ankylosis. So how do we diagnose ankylosis? Tapping on the tooth will make a metal sound, or we may see some changes on the X-ray where the PDL disappears and replaced by bone. So I would say in adult, do nothing, because adults, all the processes are slower. Remember how we said it's rapid in kids? So it is slow in adults. It will be a slow process. So the tooth will not be replaced whole by bone and disappear. It will be very slow, and portions may be replaced by bone. And we don't care so much if it is ankylosed, because there is no growth anymore. There are no changes in the skeletal relation between the teeth. So let it be ankylosed. There is nothing that needs to be done, actually, if we talk about ankylosis. The answer is different in kids, because kids, they need to grow. And if there is an ankylosis of a tooth in this critical age between 9 or 8 to 12, what happens is that the other teeth, they keep erupting, the maxilla keeps growing, but the ankylosed tooth stays apically. And actually it can create a big defect in the bone, like a big crater. So that tooth will stay stuck in the nose, in other words, and the other teeth keep erupting. So there we want to do intervention. And the rule of thumb is to find how much infraocclusion we have. So if we have more than 2 millimeters of infraocclusion that we notice, and usually the good area to look is at the gingival area, because incisor may be different if they break it or grind it. So looking at the gingival area of the teeth, if there is discrepancy of more than 2 millimeters, it means that there is already infraocclusion and it will keep being worse. This is when the decoronation is recommended, because when we do the decoronation, we cut the crown away and we cancel we cancel the fibers that go between the cervical area of the ankylosed tooth and the adjacent tooth. We cut them, and then there are new interdental fibers growing between the healthy teeth. So the whole system can grow together in harmony.
Okay. So for children, we do decoronation, and for adults, we let it first.
Yes.
Okay, there are more questions coming in. Is it possible to do decoronation if the pulp is necrotic?
Yeah, it is possible to do decoronation if the pulp is necrotic. I suggest reading the paper by Malgram that has all the steps how to do decoronation and what is needed. But we want to remove the infection first, like address the infection first, and then do the decoronation. And we don't want to leave any obturation material inside of the canal when we bury the root, because eventually we want the whole root to be replaced by bone and not to have gutta stuck in the bone for future implant.
Okay. And next question. As far as I know, we can use arch wire and brackets to splint the tooth. Does the force exerted from the O-ring will impact the healing process of the tooth?
So I just want to make sure if I understand it correctly. The question is that the recommendation is to use the wire and etch and bond and composite to splint the tooth. And the question is if the splint gonna influence the healing.
No, I think they are talking about using orthodontic bracket. We use arch wire and bracket. Can we use arch wire and bracket to splint the tooth?
Yeah, so personally, I do not use brackets because I wasn't trained to put the brackets. All the studies that were done, they were not using brackets. They were using a simple composite and the wire, because this is what is available. And yeah, I'm not aware of implications, but the idea is that we don't want to induce active forces on the teeth, like in orthodontics when we use brackets and we want to move the teeth somewhere. The goal of the splint is like passive splinting, just to support the teeth so they don't get trauma with normal chewing forces, just to allow this initial stabilization. Yeah, so I don't see a need to use a bracket.
So
Because
passive.
maybe even like placing it in the bracket and removing it may induce some unnecessary forces. So we want to be really gentle.
Okay. Another question. Thank you, Prof. Yuli. Which is your material of choice for obturation of incisors with vertical crown root fracture?
So if we have a vertical crown root fracture, then we're in trouble. Because if the fracture is going below the crestal bone, we may be in trouble in terms of controlling the infection, because it's like a highway for bugs to penetrate. There are some reports now that even if the fracture extends to the root, there is a way kind of extend the life to of the tooth. And the recommendation is to place the GP below the line of the fracture and above the line of the fracture to place composite. But we still need, yeah, enough follow-up and bigger studies. And it is compromised when it is extending into the root and below the crestal bone.
Okay. So I think those are the questions asked already. So so thank you everyone who participated. Thank you, Dr. Yuli. And on behalf of Malaysian Association of Paediatric Dentistry, thank you all for joining us in this meeting in conjunction with Global Dental and Oral Trauma Day. So all participants, please don't forget to fill in the form and don't miss the chance to get free membership of IEDT for the year 2026 by registering before tomorrow. Until next time, take care and continue making a difference in the life of our patients and community. Thank you and have a great day. Thank you, Dr. Yuli.
Thank you.